the initial part of INDIAai project, we were profiling most of the prominent AI startups. You got the Nikki AI and all the Haptic, all the early players. And one startup that always caught my interest was Niramai. One reason is how you managed to have the AI part in the name. Second part was the purpose, right? I mean, you see when almost all of this, let's say the pioneering AI startups, after 2015, this years, they were all in a consumer area, basically working on chatbots or working in retail. You had this startup which absolutely taking a different course and saying, we want to make cancer screening affordable. That's the, I think I personally, I was talking to Ashika also a few days. That's the point where I also got inspired personally. You know what? All the time the AI work I have been connected towards is mostly consumer electronics. The Siris, the Alexas, NLPs, all those things. And here is a different model. So I want to say on this month, the Breast Cancer Awareness Month, it's a privilege for me to have this conversation with you, Dr. Geetha, and I consider myself very lucky to have this conversation. And so, can you tell me how your journey started to Niramai?
Sure. Thank you very much, Mr. Jibu, for your kind comments, and really appreciate all the nice things you said about Niramai. Basically, I am an accidental entrepreneur. I was a computer scientist. I am a computer scientist and an innovator, if you will, broadly. I was a lab director at a multinational company, Xerox Research. Before that, Hewlett Packard Research for over 17 years. And I hold a PhD from the University of Science in the AI topic, and also a management degree from Kellogg's. So with that kind of a background, I was actually a lab director, and sort of we had multiple projects. We had multiple projects in my lab, which is an AI lab, essentially data science lab. We were catering to education related use cases, customer care related use cases, as well as transportation of smart cities, use cases, and also healthcare. As a multinational company, our focus was mainly on Europe and US markets, and then trying to see how AI can help in the sort of moving the business front and so on. And at that time, we did have a small initiative for emerging markets. My manager at that time, Manish Gupta ji, and we were working together on this services for emerging markets. In this exploratory activity, we were also working with local hospitals to try and see what else we can do. And it was like, can I predict a particular disease happening? Let's say, for example, when a person is in the ICU, can we predict when the person is likely to sort of die? And so you can actually sort of prioritize the patient and save the patient, and these kinds of things. Around that time, one of my cousin sisters, Bharti, she got detected with breast cancer. She was around 40 years. That's about it. And it was late stage suddenly. And I got really disturbed, very disturbed, because, she was very close to me and so on. And suddenly, you see that just a person who is next to you suddenly, and the doctor says a few more months to go. So it's really, really shocking. And that's when I started reading about breast cancer and so on. And, within 6 months, my husband's cousin also got the same thing. So it was really, re-emphasizing the need for something in this space, which is not available today. So I started reading again, and could be serendipity, I would say, that I started discussing with my colleagues. And Mr. Mehta, Dr. Mehta, he mentioned to me about thermal imaging. He said, have you looked at it? Long back it was used, and he's a multispectral imaging specialist. So he said, okay, this is something that I've been used before. So I started reading about it, and then with some support, we started a project just to sort of explore thermal imaging. And I'll tell a little bit more about why that's better than the others. So once I started spending my night times and sort of weekends and all that, and one or two part-time researchers, sort of we developed some initial elements. And I thought use of machine learning may be helpful to increase the accuracy. So we started experimenting with machine learning. And after about 1.5 to 2 years of research, I said, okay, I can't be doing this only on weekends and nights. So I quit my job and started Niramai. Niramai means being healthy. Sarve santu niramayaha. Let everyone be healthy is our motto. It's a line from the, I guess, the Vedas. And we have an expansion that's a non-invasive risk assessment through machine artificial intelligence. So that's how we started Niramai. Me and my one of my team members, product managers, Nidhi Mathur. So both of us were co-founders, but we have a co-founding team, Shiva and Himanshu, who will also definitely be part of this whole effort.
It's a very motivating and inspiring journey, I had to say, Geetha, Dr. Geetha. So the thing is, I mean, I had done like as a part of someone in this area. I had a conversation very recently with Amit Sethi of IIT Bombay, who works in medical data and things like that. So we were talking about cancer diagnostic in particular. You know, there are many options out there. You know, you got digital mammography, tomosynthesis. Then you guys developed thermalytics. So how is this different from the other existing methods in the field?
Yeah. Yes, you're absolutely right. First of all, I want to say that breast cancer is a major problem today. About 25% of all cancers is breast cancer. About more than 500,000, like 600,000 people die every year because of this disease. And then 15% of the deaths are happening in India because of late detection. Now, when you look at the current methods, which you mentioned, right, mammography, which is actually proven to increase survival rates when used regularly. Having said that, it does work and is recommended only about 40 or 45 years of age, depending on which country and which guideline you look at. Because of that, women under 45 years of age do not have a regular test that they can go to. Sometimes sonomammography or ultrasound is used, but that is extremely skill dependent, and it's very hard to actually sort of find small cancers with just sonomammography. You always need to use this as a correlation modality. Now, with that into the picture, what happens is that there is a huge gap for women under 45 years of age. In fact, even for women above 45 years of age, there's what's called as dense breast, which is there are more fibroglandular tissue in the breast, in which case, when you take a mammogram, which is basically X-ray of the breast, where the breast is compressed between the two plates and X-rays are passed from top to bottom, you'll be able to find small lumps. That's the principle because it will be white in color and so on. That's the principle in which this works. And so that will not work for women under 45 years of age and women with dense breast, because the whole breast will appear white and you're trying to find a white spot. And that's a huge limitation, because it's a physics limitation. It's not about mammography or anything. It's a physics limitation that if you use density differences, the only thing you can find is lumps. And, early calcifications, we say, you can find it. But you will not be able to easily find it in dense breast, because obviously density differences disappear. So that's that being the baseline, we decided, why use X-rays? Can we use some other modality? That's where the thermal imaging aspect, which I briefly mentioned before, comes into the picture. When you use thermal imaging, what happens is that it tries to give the temperature. It actually gives the temperature on the skin, which basically mimics the metabolic activity that is happening behind the skin in some sense. So what happens when there is a cancer cell is there's higher mitotic activity. There is higher cell division, irregular cell division. And that results in an increase in temperature at the tumor area, as well as there is more blood flow to feed to these cells. And so that results in some kind of an abnormal pattern around the lesion. So all these can be sort of, seen in the thermal image. I say sort of because it's not easily seen. Like, you can't just look at it and say, yeah, this is the thing, right? For late stage, you can always see an asymmetry, right? One side will be sort of much redder in nature, and other side is not. And you can see it for late stages. Having said that, for early stage detection or even regular screening, a hand examination or just a sort of bare eyes kind of manual examination is not sufficient. That's why we bring in the machine learning part. Thermalytics is thermal analytics, which is thermal images and analysis over thermal images. And that's where we've developed novel algorithms to analyze and, predict the probability or likelihood that it is, malignant or abnormal in general. And also we mark the area of malignancy automatically. We say, okay, here is a problem. likely to be a problem, most likely to be a problem. It's not a final diagnosis, because after our test, we say, why don't you do an ultrasound at this area? If ultrasound is done on a targeted area, it's very effective and can be done by everyone. So that's what we point out, and based on ultrasound results, further treatment or biopsy and other final diagnosis can be performed. So
is
another
quite.
thing that I forgot to
Yes,
add
please
is
continue.
sorry. Another thing I forgot to add is that it's a completely non-invasive test. It is radiation free because we just measure the temperature. There is no X-ray, so there's no side effect at all. Secondly, it's a privacy aware, in the sense it's a booth where the lady enters and sits in front of the imaging device, and she gets out after 10 minutes. That's it. Nobody would have seen her. Nobody would have touched her. Of course, she has to remove the top clothes, because that's the only way breast cancer screening can be done. But nobody would have seen her. So I call it changing room experience. How many of us go and try out new clothes in malls, right? Obviously, the door is closed. That's exactly the experience we give. So we have seen so many women adopt it because of that privacy aware nature itself.
Not just a changing room, even in security check, we had to go through a process which is much invasive, and we still had to
Right.
go through. So considering that, this is a blessing, I will say. So this technology is efficient on, I mean, there are multiple kinds of breast cancer, like you got metastatic breast cancer or ductal carcinoma. So this is applicable in all of these cases as well.
Yeah, it's locally invasive cancer. I mean, so whatever is related to the breast, that will be caught, because typically what happens is there's something called a segmentation process. We say, okay, what area of the chest region you want to analyze? And we also have to do an automatic segmentation. We sort of figure out what is the breast region and do the analysis. We also analyze the axilla, which is like below the arms, where you'll see lymph node metastasis. So that can be detected. For the rest of the metastasis, because sometimes really late stage breast cancer, can lead to cancer in the brain, lung, and other parts of the body. So those things are not included in the current version. Having said that, in the long run, we could do a full body analysis and try and come up with some other additional elements. So this is basically a first screening or early diagnosis tool for breast cancer.
So
Yeah,
if I'm
it can
correct,
detect invasive cancer or DCIS and many of these.
so
All the categories.
if I'm correct, thermalytics pretty much looks for the rapid multiplication of tissue cells. So
Abnormal tissue
up
activity,
to
you
so,
would say, right?
then it can be replicated in other parts of body as well.
Yeah, it can be. It can be. But right now, clinically proven results are for breast cancer.
Yes.
And we are very happy to collaborate with other doctors. And a lot of people have come forward also. We are evaluating which is the next size. For example, head and neck cancer is coming out, prostate, cervical. So all of these can be also, evaluated to see where is the highest effectiveness. Because of the non-contact nature, and also we have a portable device, right? It's a handheld device also, or you can fix it on a tripod, depends on what part of the body you're imaging. So that makes it very simple to also image. Non-invasive nature is very, very important.
I remember going through one of the proceedings of the San Antonio's conference. I think it happened in 2018. San
Yes.
Jose, I think, yeah, San Antonio, Texas, yes. So there you co-authored, I mean, Niramai presented a paper, and it's claimed to have 90% sensitivity rate on the detection of breast cancer, which is, I feel it's incredible, because by going through all other papers recently appeared in both Nature as well as Lancet, I mean, especially in terms of digital mammography, the sensitivity seems to be somewhere around 70 to 84% is the average. And are we in a position where we can say that these tools can provide a more accurate result compared to a radiologist at this point? I mean, using the traditional methods.
So what I would say is definitely more sensitive than X-ray based analysis, because as you know, mammography is also interpreted by a radiologist. And it's really not about whether the tool can replace radiologists or not. It's about being an additional tool for a final diagnosis of the cancer of the patient itself. Having said that, when we do rural camps, where it's difficult to take a radiologist along, and also we can't even wait for 15 minutes for a doctor to come and review, because there are these lines of people, they come in, they review, and then they go away. They come from far off villages, they go away, right? So you have to provide immediate, literally real-time results have to be provided. So that is the place where we have enhanced the solution to give provisional reporting, not the full-fledged reporting of whether there's any major abnormality or specific abnormality at this place and all. So there we gave what is called as a red, yellow, green, or a traffic light output. That's all. It's like, if it is red, please come to the side. We may want to do a re-examination. Yellow, come back in about 6 months, and green, she can go home. And these red people, they actually take more information about her contacts and which village and neighbor and like son, husband. So because there are several of these nuances, many of them may not even have a mobile phone. They'll be using their husband's mobile phone. So all of this data we will be capturing, and then we'll follow up only for those people, because otherwise it's very hard to get mammography to the villages and then do it at that scale, and more importantly do the interpretation at that speed, right? Even if it is teleradiology, it's very hard to do that. So in those cases, yes, we use the tool alone in a provisional fashion. Whereas in the hospitals, our report is also reviewed by a radiologist, because the radiologist has several other information about the patient. Many other tests could have been conducted, and they may see something additional, in the reports. So we give a quantitative report with scores and then send it to a radiologist. The radiologist can also review it on a phone. We have a mobile app called Niramai Doctor that can be downloaded by the doctor and review the reports that are assigned to the doctor. And then only certified reports are given to the end users. So that we ensure. So it's really not about replacing doctors. It's making them more scalable and more productive, I would say, in an urban scenario, and enabling affordable and high quality care even outside the tier 1 cities or even villages and so on. So I think that's very, very critical, and I feel very deeply about that problem in India.
I completely agree with you. So one of the, like you said, the breast cancer is one of the, considering that, women are half of the population, yet the total number, the volume of breast cancer patients is higher. And the fact that in our, considering the sensitive nature of rural India and lack of access in rural India, this is a very serious way to address some of the problem. I mean, there is a general tendency to believe that cancer is, obviously around urban area because of environmental pollution, all these things. But even I work closely with many NGOs, and you can see many rural areas, the problem is you end up diagnosing in the last part of the stage. And very recently, someone who's very close to me, she's 75, she was taken into hospital for TB, but further ultrasound, they realized it's a cancer and it has expanded to her ribs, and now it's a waiting game, right? So in that, in that case, something like what Niramai is doing, right? How you can implement this, go to the villages. I mean, the key part is informing them, there is something wrong, that you need to check it out, so that they can go to the next town or city where they can get better. I think that first stage is very crucial, and I'm very happy to hear the work Niramai has been doing. So how can we scale this up? What are the challenges right now, Niramai or anyone else coming into this space have in terms of scaling up?
Yeah. So obviously, a small team cannot solve a a big problem which is attacking the world, right? Yeah. So we look for collaborations and partnerships. And in particular, we talked about rural scaling. And so for that rural scaling of the test itself, we partner with cancer societies, NGOs, nonprofit organizations who actually have all the capacity to bring people together, to spread awareness at that. And of course, we're very much looking forward to partner with government at that scale, right? The PHC level, in order to take these solutions there. And then at the urban level, also, it's a very important problem. We talked about how, women under 45 do not have a test, and also women with dense breast, which is almost 50% of the ladies above 45. So for these people, we partner with clinical experts, particularly in diagnostic centers and hospitals, to provide that solution as one of the tests, like a preventative screening or general tests that people, any lady coming in can take this test, in the hospital. And for this, we also have partners in almost every state. We are recruiting partners in some of the states, but many states, our solution is already installed in about 14 cities today. For example, Bangalore, Mysore, Hyderabad, Pune, Delhi, Mumbai, Dehradun, Orissa. So many of these places, Chennai, all of these places we do have. And some of it is delivered through the partner. So once partner means basically we sell the solution, train them, and they become experts in doing the solution themselves. For example, our Hyderabad partner, we have a center called Mumang. It's just in a mall. It's like a simple, like a shop. One could go before buying a saree, should go get that done. And it's just as simple as that, because nobody sees, as I said, right? So they're also doing camps around it. So it's like a station place, because our equipment is very simple. It's a small device, just like a 1 liter water bottle. So you can actually install in a hospital as well as do the rural camp. So we have the station, like a hub and spoke angle to it for the scale up. So that is done. And yes, we are partnering, and we're also partnering with diagnostic chains. And recently you would have heard we partner with Apollo Clinics. And right now we're providing all Apollo Clinics in 4 cities this particular solution, and it's appointment based. A person can take an appointment from Apollo Clinic, and we'll let the device go there and do this training. And then we plan to expand pan India, and also partner with other diagnostic centers who are coming up to actually do this, because the other beautiful thing is it's no contact. It's also COVID friendly, right? And when people are not coming into the hospital because of this pandemic issue and scare of getting infected, we have also launched home screening. So, anyone can come into our website and register for screening with their PIN code. Our team will call up and then set up an appointment, and we send the technician with the equipment to their home, right? This is the first ever time cancer screening is done at home. And so I really actually urge everyone to make use of this. I would not. But that's how we are scaling right now.
This is exciting, Geetha, because I mean, these are the things that actually inspire me to look into AI as this technology that is capable of making these things accessible, right? You mentioned the challenges had in this area, and I also noticed that one of the constant criticism any startup or a product in healthcare sector gets. I mean, many notable people points out is that, see, you can get a good result for a paper, you publish it in Lancet or Springer or Nature
Absolutely.
with a particular data set, but that won't be the case when you go into a production settings. And the
Yeah.
case of Niramai seems to be totally opposite to that, because you guys are doing quite well in a real life, real scenario, and that's been fascinating.
Yeah. No, actually, there are challenges. I mean, we were taking Mickey Mouse steps. Initially, of course, it was working inside a lab. And then the first thing we did was a clinical validation in a real setting. The way you train and test a model inside a lab is very different from how you test a model to be used outside. It's like, how does the model behave for an unseen data, right? That's very, very important. It's called as prospective setting. That is, when you don't know the label, are you able to predict? I mean, it sounds so silly. Of course, if you don't know the label, you have to predict. But that's exactly how it has to be tested, and it is not tested. All the AI models in the lab are not tested that way. Generally, it's based on several other, like cross validation and so on. The labels will be known. I mean, maybe it's not known to the model, but it's known to the person who is training the model. So there's always this bias to make it look good on the training testing set, and sort of choose the training setup appropriately and so on. Whereas in our case, we really, really don't know the answer, and the person is coming in. And so we had to do deep clinical trials, where the person comes in, takes our test, and we give the result. And there's an external body who will also look at what their mammography and ultrasound tests are. They compare and then actually do the publication. So all this, that's the reason why we took 3 years almost to kind of scale up. We did it like one by one, making sure that we are doing the right thing. And now we have screened about more than 32,000 women, and published in 6 international conferences and journals. The latest one is an ASCO JCO, which is one of the top tier conferences, journal papers that we have published. So with this, I think, and also there's a lot of innovation that's gone in. It's not like, just took the images and sort of churned it through a deep learning network, which is pre-trained. It's not been that way. There's a lot of semantic, data engineering, data science, and novelty that's gone in, which has resulted in 10 granted US patents. That's just the sort of the novelty that has gone into the algorithm design itself. Is unique. So thanks to our wonderful team, a lot of bright ideas. We brainstorm a lot, and we are here. And as a technologist, I feel very good, just like what you said, right? how can a technology predict, so well, especially we have asymptomatic sensitivity of 100%. It's like, oh my God, I keep touching wood and saying, okay, we shouldn't make this thing any case, right? So, I mean, it's really good.
So that's also since you mentioned the specificity rate of 100%. That's
Sensitivity,
very
yeah.
that's almost like impossible to accomplish. But
Yeah,
uh,
so both 100% is absolutely impossible, like
yes,
sensitivity and specificity.
specificity. Yeah.
Sensitivity is 100%, specificity is about 94%. Means basically we may call out a few people who are not
Yep.
cancerous as cancer. So we do not actually say cancer or whatever, we just ask them to go for a follow-up test. And that's the main thing we find. So even if Niramai test say positive, it could be maybe like a deep infection, right? Which can come out as a higher metabolism there. It's also good for her to show it to the end. So that is what our meaning is.
So I mean I've been going through some of the the machine learning models and everything developed for COVID diagnostics, and you see this general pattern. You have around 90% sensitivity, but the specificity will be like 40% or 50% maximum. And I
Yeah.
think this is a wonderful news. So Geetha, as a accidental entrepreneur, but now a successful entrepreneur and quite inspiring person as well. How I want to have two questions to you. One is on a personal level, and another is on a general national level. So my
Sure.
personal level question is: it is quite challenging, as we know, we live in a society where rules are different for man and woman. And I feel privileged saying that. I'm not happy about saying that, but we know the reasons, right? And it's always been what I have seen in the work environment or everywhere. A woman has to be twice good as a man to be in the same position. And because of that, I was blessed with so many good mentors, because they are always best at what they do. So in that case, how difficult was your challenge as an entrepreneur? I mean, you co-founder were both woman, and what is your message for other female entrepreneurs out there?
Yeah, definitely it's challenging. I'm not going to sort of reduce that. It's like that, right? So if you suddenly find a lady driving a pilot, a lady pilot in the flight, or a lady bus conductor, you suddenly feel, how is, like, suddenly there is a different opinion. In the same way, right? A business should be run by men, right? So yeah, so that outlook is there. So there is some kind of a doubt all the time when you say some things and so on. But uh, couple of things. I think it's about being ready with some facts whenever there is a question raised, and then showing with some proof points. And it's not just for entrepreneurship. I think it's true for any senior technical role, the innovation role that I've played before. Also, in all of these cases, I used to be sort of the only lady around the table and all those kinds of things. So basically, initially, it's extremely you're awed by the fact that I don't, and I'm not by nature outgoing, so it's very difficult for me to sort of break up the shyness and come out. But then what happens, you're the theme that you're going after, right? You are looking at, I mean, so many ladies can benefit, and if I shut up and don't talk, and I'm actually not doing injustice to it. So that gives me the power to speak up and explain what I think is a good idea to be shared in the table. And it's possible that people may laugh at me. Let them laugh. I mean, because at the end of the day, if you start caring too much about outside, right, you can't do what you want to do. So I think that is one thing. It's very hard to get to that mindset. I'm still not saying I'm 100% there, but it does hurt me, and I go back and say, but still, right? That is one thing. Gaining the courage to speak up what you think is right, I think is very much important, and you need to train that. Even when there's like the small girls, we are seeing like that leadership type qualities more now, but that needs to be done. So that's definitely a challenge. And so typically you end up doing double the work, possibly before saying a statement than a male colleague. And yeah, and also you're perceived, whenever you say the statement, the other person is perceiving it as maybe it's half true, right? So it's like really crazy sometimes. And so you come up with some facts and all, then they say you're being defensive. No, I have all the results ready because I'm expecting this question. So it's pretty hard. But I think because we are solving a women's problem today, some of the people also perceive that we can understand those problems much better than, let's say, a male co-founder. But we do have considerable male colleagues in our team as well, though we are about 60% women. I mean, it's. I think it's just the teamwork that can finally take you through there. But you'll have to find the voice to speak up. That's all I would. I would just encourage all ladies and girls to do this.
That's truly inspiring. One more question. Now we were talking about, I mean, the overall theme. Something I'm also very curious about is how can we make healthcare? We spoke about cancer screening, but other parts of healthcare. How can we make all these things more accessible to rural India? That's the biggest challenge, right? Like we can talk about using a tool like Niramai for a radiologist in a city like Bangalore or Cochin or Chennai or Delhi or Mumbai, but there are towns or villages where you can't even have a proper screening facility or a radiologist, a hospital. All these public facilities, and some of the states, I mean many of the states in our countries, public healthcare system are not up to where our ready to meet our people's need and aspirations. So how can we leverage this power, like what Nirma is doing with breast cancer? How can we leverage AI to have this way approach towards the healthcare system, where especially diagnosis can be made very easy and accessible in other areas as well?
Sure. Yeah, definitely. It's a very good question, Jibu. Um, I think there are two things that need to be done, right? So one is organized screening programs, so because one way is to actually set up those centers in every village, and that becomes, too expensive for us to manage, because also for the fact that it may not be fully utilized, if you invest in the small equipments that you want to use for. So having some kind of good screening programs, maybe like a mobile van where you have all of the stuff and it goes like maybe even once a month to every village. That is good enough to screen all of the people. So that is one, and more from a structural and organizational perspective. And second is provide these AI-based tools inside this, or of course, it may not be running inside the machine, inside the bus, sorry. It can be taken out, and we have done the camps inside a bus, or even like in primary schools of every village, right? You can just take a room and set it up there. And there, we can't expect doctors to go everywhere because they're busy already, right? And doesn't scale to every village. So there, this kind of AI tools will help a health worker to enhance her skills, increase her quote, quote skill set in an artificial fashion, if I can say that, and provide tools in a way that she can use those to provide high quality healthcare in a real time and provisional manner, right? So that, I think, the combination of AI tools which can be used by simple health workers and a combination of a structure which takes these people to different places, I think this combo is what is the most important place. And with that, I believe, we can provide, affordable, accessible healthcare for everyone. I think I'm really looking forward to that day. And, at Niramai, we are really fighting for that cause, right? So we have installations in mobile vans, we made it portable, we are making it even smaller now and more affordable. And most importantly, we have a full training department which can provide this training to any health worker, right? Who's just maybe 12th class pass. Hopefully the day is not too far.
Thank you very much, Dr. Geetha. It was very enlightening, and I hope so many people will look up to you, get inspired, and use technologies like AI for a bigger purpose. I mean, I remember reading a quote. I can't recall the book. It says, "The greatest use of life is to live your life in a way that the purpose of your life will become greater than your life." So I'm very much privileged to have this conversation, and I'm wishing you all the best. And maybe we can catch up later when Nirmai will do much bigger things. Great to know everything you are doing. Thanks a lot, Geetha, and thank you very much.
Thanks a lot. Thank you very much.